Hello and welcome to AuntMinnieTV. My name is Brian Casey. I'm editor-in-chief of AuntMinnie.com. We have with us today Scott Cowsill. He is Senior Vice President for Strategic Initiatives at National Decision Support Company, and we are going to be talking today about ACR Select. That's a program that National Decision Support is involved with to bring appropriateness criteria of the ACR to routine clinical use. Scott, thanks for being with us today.
Thanks for having me.
So Scott, you just exhibited at the RSNA for the first time, and can you talk a little bit about how that went?
Sure. Yes, this was our first year with ACR Select at RSNA, and actually it went absolutely fantastic. We were extremely pleased with the support that we got and the level of interest. The booth was packed from the beginning of the show to the end of the show, and certainly a lot of interest from all sects of the healthcare industry. So we couldn't have been happier with the outcome.
Good. So can we talk a little bit about what ACR Select is and the problem that it's designed to address?
Sure. So ACR Select is basically the electronic version or digitally consumable or electronically consumable version of the ACR, American College of Radiology, AC Appropriateness Criteria. And in essence, ACR Select is designed to be deployed primarily in an EMR or in a CPOE, a computerized physician order entry workflow, and designed for ordering clinicians to order the right study at the right time for that patient, for the specific clinical indications and age and sex of that patient. So in essence, what we're trying to do is make radiology ordering more appropriate for the patient the first time. So in essence, if a patient twists their knee on the way out of their home and needs to go see their primary care physician, and that primary care physician thinks that the patient needs a CT of the knee, for example, you can run it through the ACR Select appropriateness criteria, and it would come back and say for a patient, a 55-year-old male, for example, may or may not need a CT of the knee for those specific indications. He or she may need a MR of the knee, for example.
Right. And so this ties into that issue that we're all pretty much aware of right now, which is that there's really a lot of inappropriate utilization of medical imaging going on. Do we have a figure on about how much imaging use is really thought to be inappropriate?
Yeah, so depending on if you're looking at the private sector or if you're looking at the public sector, so we're talking about Medicare or Medicaid, the figures vary, but I can tell you it's certainly in the millions and millions, if not billions. And Medicare Centers for Medicare and Medicaid Services is certainly taking a close look at how they can appropriately utilize imaging within CMS. And this has been something that's been going on in the private sector payers. So the Blue Crosses, the Aetnas, the Cignas, the big private insurance companies of this country have been managing utilization through third-party sources, RBMs, radiology benefit management companies, for some time. And this is a solution now that will enable not only the private insurance companies, but also the hospital institutions to help manage utilization much more effectively, much more efficiently, and for a lot less money than has been in the past.
Yeah, because the radiology benefits managers are a little bit controversial. I mean, nobody really likes having to pick up a phone and make a phone call every time you want to order an imaging study. This is designed to be a little easier for them to use than an RBM?
Oh, absolutely. And that's one of the initial intents is in order for information to be, let's call it deemed useful, it has to be consumable and it has to be actionable. And we all know that making a phone call in the middle of ordering an imaging study, whether you're in an outpatient facility, ambulatory facility, or if you're on the floor on the inpatient side, picking up the phone and trying to get pre-auth or pre-certification for a study just doesn't really, jive with the workflow, so to say. So
right.
This being in electronic format and digitally consumable right in the CPOE workflow, it's at point of order, so it couldn't be more timely and more actionable. And it assists the ordering clinician in getting that right study the first time.
Now the ACR has had appropriateness criteria for some time that's been designed to give doctors a little bit more better guidance into what to order. How is ACR Select different from that, and how is it expected to be a better tool?
Right. So ACR Select is the first electronically available version of this. This is something that the ACR, American College of Radiology, just announced with NDSC, National Decision Support Company, this past July of 2012 to enter into this venture to basically take the commercialized version of the appropriateness criteria in the electronic format and try to proliferate what we know are probably some of the best guidelines out there for imaging. And in doing so, the objective is to help the ordering clinicians and to help radiologists on the back end as those receiving these orders and rendering the services to understand why it is and have captured structured indications for the reasons that they're doing the exams. So this is the first opportunity that we've done it. The appropriateness criteria in the past were in paper format, in booklet format, PDF, so they weren't usable in that CPOE workflow that we were discussing. I'd also like to add real quick that in discussing the RBMs, I think one major difference between the ACR appropriateness criteria or ACR Select is that it's extremely transparent, right? So I think later on as we get into this a little bit more, I can show you some examples, but everything behind the scenes, all the rules and the guidelines themselves are very transparent to the end user, and from what I hear about the RBM industry, that's not necessarily so.
Great. Well, can we see an example of what a screen from ACR Select might look like?
Sure. So this will be an example of what ACR Select looks like accessing it from what we call our portal or a web use. So this would be an example of how an individual would get access to the data, so to say, if they didn't have it integrated into their EMR, electronic medical record, or their CPOE workflow. And I'll bring that up for you here.
Because you think that ACR Select could be used in a couple different ways there based on what kind of software people have?
Right. So as you know, the majority of this country are switching to electronic medical records for a lot of reasons, meaningful use being a big one, and I'm sure many of your readers know about that. So as we switch to these electronic medical records and these CPOEs, computerized physician order entry workflows, again, this information has to be worked into that logistical workflow so that it can be used and it doesn't become another click or another nuisance in that process, right? So two ways really it can be accessed, that through the EMR or CPOE, and we're working on those integrations as we speak today with the EMR vendors. Or if you don't have an EMR that you're using, you can access it just via the web through what we call our portal here. So this is just an example of a screen. This is a screen after you've actually run a request, but you can see that we've asked for a query on a 55-year-old male here for a CT ahead. So if you can imagine, you as the viewer here, if you are the ordering clinician, you would come in and you would simply say the age and the sex of the patient, so with 55-year-old male. You could click on modality here and it would drop down and give you all the modalities that are covered. And we're talking CT, CTA, MR, MRA, breast MR, PET CT, and so on and so forth. The list is pretty all-inclusive. You then pick the body area that you're interested in, and in this example, let's say that this 55-year-old male came in with some neurologic complications. So we want to do a CT head. We have a list, and this list scrolls down as well, of clinical indications or signs and symptoms that I can choose from on this patient, or I have clinical scenarios that may fit my patient. And we can see here that the ordering clinician has selected cerebral aneurysm risk family history. So based on that, it then goes out to the data in our database and then returns what we call a decision support score here. And that ranges from 1 to 9, 1 being the lowest, and they're color-coded. So 1, 2, and 3 are red, 4, 5, 6, and 7 are yellow, 8 and 9 are green. And most people understand green is go, yellow is yield or marginal, and red is stop. But we can see here that for this request, it comes back and says that a CT angiography of the head with IV contrast is in fact an 8. And we can see that it scores higher than any of the other studies. And if I were to scroll down in this panel here, this would scroll down to all the lower of the scored modalities as well.
So what we're seeing in yellow there are the other options for this particular clinical indication?
That's exactly right. So all the other alternate studies for a 55-year-old male CT head for the reasons cerebral aneurysm risk family history here. And again, this scrolls all the way down, and you can get all the way down into the 1 and 2, 3 scored region. Right. And it's very important to understand, and we get this quite often, people say, well, why wouldn't you just show the ordering clinician just the appropriate study, right, just this one? And most ordering clinicians would stop me right there and say, no, it's very critical that I see all ordering exams, regardless of how they score, because this is in essence a medical reference or a medical education tool.
Right.
And if I see all those, I can learn from it, and then I know not even to think about that or consider that as an order next time. Whereas if you didn't show me that, then I wouldn't have that education.
So this is a tool that's kind of generating real-time feedback for the ordering physicians that they can kind of use in the future.
Absolutely. And then to piggyback on top of the fact that I was talking about the transparency of the guidelines, you can see that I have an evidence link here. So if in fact I were to click on that evidence link, let me share what would come up with for you there. And so, can you see that, Brian?
Yeah.
Great. So if an ordering clinician were in fact interested as to, okay, well, why is it scored like that, or how did the expert panels at the ACR come to decide that this is, of this score, or more relevant, let's say, than some other study? It's all right here in these ACR white paper PDFs that exist in the background for the evidence behind why or why not the expert panels made the decision that they made about that specific test.
And does this provide a little bit more information that a referring physician might get from an RBM in terms of why a study is being approved or not really denied in this case, but why it's not preferred?
Right, yep. So again, since I don't work for one of the RBMs, I can't speak with 100% certainty, but I can tell you from our experiences in talking to ordering clinicians, this is a lot more information that they get. And not to mention, remember, it's accessible. It's right in front of them. They can read it. It's right there. It's pertinent at that time, as opposed to if I save all these, like I know many clinicians do, till the end of the day, and we just make them in a big batch phone call, it's not really relevant at that time, and so it doesn't mean as much if I can't get to the rule or the understanding of the rule at the time I'm making the order.
Gotcha. So where do you stand right now? Where does ACR Select stand right now in terms of clinical use, and how are you trying to get folks to be using the software?
So let me come back here. So right now, people are extremely interested. As I had mentioned, all the interest that we received at RSNA, and I can tell you that we have a couple sites. ACR Select, for example, is being used at the CMS Imaging Demonstration Project sites. We have 2 of the 5 convener sites that are using ACR Select.
And
so,
what could you talk a little bit about what exactly that project is?
Sure, I'd like to. So CMS, as part of the MIPA 135B bill, set aside, I believe it was $10 million to do what they called the CMS Imaging Demonstration Project. They selected 5 convener sites, and a convener site are providing institutions around the country, and they decided to do a clinical decision support demo or pilot to see the effectiveness of clinical decision support. So 2 of those sites happen to be using ACR Select. And what we're hoping is that after this 2-year demonstration project, that they do their data analysis, that we can then have some pretty solid data as performed by CMS themselves that clinical decision support is as effective, if not more effective, than RBM management for imaging.
And so CMS is commissioned these projects because they're trying to get a handle on Medicare utilization, better ways to reduce inappropriate utilization, because if they can do that, then they can save money on Medicare. That's correct?
That's exactly right, yep. So as the chair of the Imaging E-Ordering Coalition, and we have quite a few large members, we've spent a lot of time in Washington, D.C. trying to help educate policymakers in understanding that RBMs aren't their only option for managing utilization within the CMS population. And in saying that, I think they understand that it's not too long, if it's not already occurring, that radiology is going to be the most expensive component of Medicare. It used to be pharma, and you can see what we had to do with e-ordering or e-prescribing. And so e-ordering of imaging is not really that different. It's just a different segment of CMS, and we're trying to manage it the same way.
Right. Now, when do you think we're going to see some data from these CMS pilot projects, and that will give us an idea of how well tools like ACR Select are working?
Right. So I know there's preliminary feedback, nothing that's been published. Obviously, we're in contact with the sites that we support, and from my understanding, sites are in various segments of the demo project. Some a little bit ahead of others, and some farther behind. But that being said, it was a 2-year pilot, and I believe where most sites are 6 to 8 months into the pilot already. So I would imagine the remaining, let's call it, year and a half, then plus some data analysis time. Unfortunately, I wish we had the data sooner, but it'll probably be about 2 years before we see anything published on the significance and the impact that this has had.
Okay.
And we're expecting to see positive data.
Good. And I understand you've also been talking to federal officials about ACR Select and what kind of role it can play at that level?
Yeah, so again, going back to the coalition and in talking to members of the coalition as well as using clinicians and large academic institutions across the country and just small neighborhood commercial institutions, hospitals and provider networks, I think it's fairly unanimous that ordering clinicians alike are all looking for what they consider kind of a national standard for imaging guidelines. And so what we're hoping is that the ACR Select slowly becomes that national standard. It's the best, most robust set of data that we know of, and again, the best way to get it in use is to get it out there and get it into the hands of the using clinicians at the time of order so that it can be actionable right then and there.
So this could potentially become a national standard for ordering imaging exams?
Absolutely, yep.
Okay, great. Good. Well, Scott, anything else that you'd like to add?
No, again, I appreciate your time and the interest, and obviously folks can get more information on ACR Select, our National Decision Support Company, at our website, www.acrselect.org.
All right, very good. Well, Scott, thanks for being with us today and talking about ACR Select. Signing off for AuntMinnieTV, my name's Brian Casey.
Bye-bye.